I'm Ajay Nooka. I'm an associate professor at the Winship Cancer Institute of Emory University. I'll be discussing about how disease biology can influence the treatment decisions. As we are aware, the myeloma genetics differ by the race. And these myeloma genetics have a relevant prognosis for the specific patient. The good thing about understanding these genetics is it helps us to understand the prognosis much clearer. African Americans have lesser high-risk features that have commonly been described. The high-risk features that are described were deletion 17p, amplification of 1q, translocation of 414, etc. And deletion 17p in one of the datasets that we have evaluated in 1,000 patients was more concentrated in the Caucasian patients, up to 12%, and it is half of the incidence in the African American patients. It was close to 7% in the African Americans. The same numbers for amplification of 1q are 19% in the Caucasians and close to 11% in the African Americans. If you flip it the other way, the standard risk disease is more common in the African American patients compared to the Caucasians. One of the genetic abnormality of more significance, which could be targeted with a BCL2 inhibitor, which is translocation of 1114, is more commonly seen in the African Americans compared to the Caucasians. In the African Americans, it is seen in 16% of the population. In the Caucasians, it was seen in 11% of the population. Using the COMPASS dataset, if you look at all the patients that had non-translocation 1114, excluding the patients who had 1114, the overall survival as well as the progression-free survival are similar across both the races. But if you specifically look at the translocation of 1114 patients, African Americans have a poorer progression-free survival as well as an overall survival. I would argue that this is more related to an access to the care, as the patients with translocation 1114 respond very well to venetoclax, which is the BCL2 inhibitor. And right now, probably this group of African American patients are not getting the access to the specific agent, showing that translocation 1114 in African Americans is conferring a poorer prognosis. If you look at this same subset of patients in our institutional data set, even though it's a smaller number, African Americans have the same kind of responses or a better response than the Caucasians and much deeper responses than the Caucasians among patients with translocation 1114 that receive venetoclax. Moving gears, looking at the whole genome sequencing across the races, Ben Barwick, one of our researchers, looked at the COMPASS dataset and was able to identify these recurrent translocations in 2/3 of the newly diagnosed myeloma patients with translocation 1114, translocation 414, and translocation of the MYC, and other immunoglobulin translocations, which differed by the race. So the MYC structural alterations were seen in a quarter of the patients, and MYC by itself did not confer any poor prognosis. However, those patients with IGL MYC translocations, which were seen in close to 10% of the patients, had significantly worse PFS and overall survival. The MYC translocations have worse outcomes, and the IGL locus contains multiple strong enhancer elements that are bound by the ecros, which is the target for the IMiD, possibly conferring the IMiD resistance, forming the hypothesis that differential therapeutic responses exist by the race based on these. The ECOG trial has evaluated lenalidomide versus observation among patients with smoldering multiple myeloma with an intent to delay the progression to symptomatic multiple myeloma. If you look at all the subgroups among patients that responded to lenalidomide, every subgroup has benefited using the lenalidomide to prevent this progression. The one subset that did not benefit was the African American patients, where using that lenalidomide did not delay the progression to symptomatic multiple myeloma, confirming our prior observations. Moving gears to the high-risk patients, how the biology can influence the treatment decisions, we have used risk-adapted maintenance for over a decade at Emory. We have used combination treatments to delay the progression across all the patients. As we had alluded to before, high-risk genetics are less concentrated in African American patients. Now, among the patients with high-risk disease, using a combination maintenance after the transplant has delayed the progression and improved the overall survival. In our analysis that was presented back in 2014, among the high-risk patients with deletion 17p, deletion of 1p, translocation 414, and translocation of 1416, using the combination maintenance with bortezomib, lenalidomide, and dexamethasone resulted in a PFS of close to 32 months and a 3-year overall survival of 93%. The same results were shown by the German group as well, who also used a CD38 monoclonal antibody, which is isatuximab, in combination with a proteasome inhibitor, which is carfilzomib, and lenalidomide, which is an IMiD, and a steroid dexamethasone before and after the transplant in high-risk multiple myeloma. And in this analysis, at the 3-year mark, close to 75% of the patients were alive. The FOTO trial, which included some high-risk patients, included 3 arms. The first arm had carfilzomib, cyclophosphamide, and dexamethasone given for a finite period of 4 cycles, followed by a transplant, followed by 4 further cycles of KCD. The second arm had carfilzomib, lenalidomide, and dexamethasone, or KRD, followed by a transplant, followed by 4 further cycles of KRD. The third arm did not have a transplant. Patients would receive 4 cycles of KRD, followed by another 4 cycles of KRD as consolidation, followed by further 4 cycles of KRD, altogether consisting of 12 cycles of KRD. All these groups would undergo a second randomization to receive lenalidomide versus carfilzomib and lenalidomide combination. When you specifically look at the high-risk patients, most of these patients did benefit from the combination of carfilzomib and lenalidomide relative to lenalidomide alone. The patients with deletion 17p, deletion 1p, gain of 1q, translocation 414, all of them got benefited by using the combination treatment. The one group that did not benefit was the patients with amplification of 1q, which again, as we alluded to before, was more commonly concentrated in the Caucasian patients. And these patients would need a very different strategy. The initial genome sequencing in myeloma was reported by Chapman's group, and they did a parallel sequencing of 38 tumor genomes and their comparison to the matched normal DNAs. And the pattern of the somatic mutation across the dataset suggested that there are several oncogenic mechanisms. These included the mutations involving the genes in the protein translation or the genes in histone methylation. A much higher role than anticipated of NF-kappa B signaling was suggested by mutations in 11 members of the NF-kappa B pathway. There were activating mutations involving the kinase BRAF, which were observed in close to 4% of the patients, suggesting that the evaluation of BRAF inhibitors in myeloma could have a benefit. Brian Walker's group did a staging system using the mutational analysis as well as the international staging system. They were able to improvise on the prognostication by dividing patients into 3 groups. The first group having a low mutational burden as well as a lower ISS staging, compared to the second group with intermediate mutational analysis and ISS stage 2, and the third group having a higher mutational burden and ISS stage 3. These 3 groups were able to show a significant difference, identifying a robust prognostic staging system than what we have for both the PFS as well as the overall survival. The MyDrug study used the information of the actionable mutations to define the treatments. Among the functional high-risk patients, based on the profiling of the alterations, their treatment groups were decided, and at least a 30% target genetic abnormality was used as the cutoff to a particular arm to increase the likelihood that it is an activating mutation, and also one of the endpoints to look at the allelic response. The most frequent genetic lesion determined the treatment arm, and this trial is currently ongoing, and these results will help us to determine personalized treatments. The biology of the myeloma is likely very different based on the race, and this may explain some of the differences in the frequency of the cytogenetic abnormalities seen in the African American patient population. Precision medicine is an important part of this process and leads to true targeted therapy. Specific trial and tissue analysis based on race are critical to understanding how to optimize treatment for all patients. Thank you.